Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, I'm going to be covering part 2 of anti-seizure medications. Now that last video that I made, I said that was part 2, but I was going over barbiturates and benzodiazepines. However, when I was covering the barbiturates and benzodiazepines, I was covering them in the context of anxiolytics and hypnotics. In this context, I'm actually covering them as anti-epileptic, anti-seizure drugs. So this is a true part 2 of the anti-seizure medications. So the first thing I want to cover with you are the barbiturates. I'm right down here. And if you get a question on the barbiturates, whether it's NCLEX, HESI, HESI, major nursing exam, most likely it's going to be your phenobarbital. No phenobarbital, okay? These are your barbiturate and barbiturate-like drugs. Let's talk about the therapeutic actions. It reduces the tonic, clonic, muscular, and emotional response to stimulation. And it makes sense because remember, seizure is what? It's overexcitement, overstimulation of the CNS. So this does the opposite, brings that patient back down. It depresses that CNS. Phenobarbital depresses conduction in the lower brainstem and cerebral cortex and depresses motor conduction. Now let's talk about pharmacokinetics. I hardly ever talk to you about pharmacokinetics, but if I bring something up in pharmacokinetics, it's important to know. I'll make sure you know it. So pharmacokinetics as it relates to the phenobarbitals, therapeutic serum level, 10 to 40. 10 to 40. Adverse effects are more apparent with levels at and above 30 micrograms. So you guys need to know that. The therapeutic range is 10 to 40 micrograms per milliliters. But once we see that patient hitting 30 micrograms or above, we start to see those adverse reactions. What are the contraindications to taking phenobarbital, to taking a barbiturate? Contraindications or cautions for barbiturates are the same as those discussed for hydantoins. And when I say hydantoins, I'm talking about like your phentoin, your dilantin. I talked about that in the last video that I posted. So make sure you guys watch that if you haven't seen it already. Adverse effects. Adverse effects of the barbiturates. Depression, because that's what it does. It depresses the CNS. Confusion. You're going to see a change in that patient's level of consciousness. Why? Because it decreases the CNS. Drowsiness, lethargy. Are you guys starting to see a common theme here? Everything in that CNS is being what? Depressed. Arrhythmias, changes in blood pressure, urinary retention, loss of libido. This is important for you to let a male patient know. And you know what? I shouldn't say male patient. You should also let the female patient, both sexes. However, when it comes to test questions, the way that I see it more framed is, you know, you have a male patient, blah, blah, blah. They've been prescribed this barbiturate, what's important to teach them. And so it's important to let them know that it may decrease their libido. Because barbiturates and barbiturate-like drugs depress nerve function, which we already know, they can produce sedation, hypnosis, anesthesia, and deep coma. Phenobarbital may be associated with physical dependence and withdrawal syndrome. That is very important to know. Why? Because it has patients are at risk for being dependent on this medication, for becoming addicted to this medication. Do you think this would be a good medication to give to a patient that already has a history of alcohol abuse or opioid abuse or any type of addiction? Absolutely not, because they're already prone for abuse. Okay. It's been linked to severe dermatologic reactions. Let's talk about that. What are they talking about when they say severe dermatologic reactions? They're talking about reactions such as Stevens-Johnson syndrome, which is fatal. It's deadly. You need to know that. And development of drug tolerance. I'm looking for a pen because that definitely is on NCLEX, and I don't know why I didn't write that down. All right, I don't see a pen, but make sure you know it, guys. I promise. Oh, where is I? Right here. That's definitely shown up on NCLEX. You need to know that. Drug-drug interactions. Now, you know by now, you don't take anything with alcohol. You don't take any medication over the counter or prescribed with alcohol. So that definitely is a drug-drug interaction. And I want you to think about it. Barbiturates do what? Depress the CNS. What is alcohol? A CNS depressant. I know in the movies, they show you a person's drinking and they're partying and they're excited, but no, it does the opposite. It's a CNS depressant, okay? All right, let's move on to benzodiazepines. These are your benzodiazepines. Make sure you know these medications. The ones I see that you're asked about the most is your diazepam, which is your Valium. Therapeutic actions and indications. Why would we give benzodiazepine to a patient? Okay, so let's talk about the action. It can potentiate the effects of GABA. When you see that word potentiate, that means to make stronger. Okay, so it can make stronger the effects of GABA. It acts primarily in the limbic system of the RAS, causes muscular relaxation, relieves anxiety. Look at this, guys. Relieves anxiety without affecting cortical functioning, decreases excitability and hyperexcitability to stimulation, which is wonderful. That's a great drug that we would use to prevent seizures. It reduces tonic-clonic muscular and emotional response to stimulation. Look at this. In general, these drugs have limited toxicity and they're well tolerated by most people. Clonazepam may lose its effectiveness within 3 months. Contraindications and cautions. Same that we see for benzos and hydantoins. Adverse effects, again, CNS depressant. So everything you can think of that you see with CNS depression, such as a confusion, such as a lethargy, such as a drowsiness, all of those which makes the patient a safety risk. Safety is going to be one of the things forefront on our minds. That's what comes with it. CNS depression, confusion, drowsiness, lethargy, fatigue. Everything slowing down, guys. Constipation, dry mouth, anorexia, cardiac arrhythmias, changes in blood pressure. We're going to be worried that the patient may have a hypotensive crisis, right? We're going to teach them to turn position slowly. Urinary retention, loss of libido. Benzodiazepines can be associated with physical dependence and withdrawal syndrome, especially with rapid reduction in dose. Let me tell you something. When it comes to these psych meds, you never not decrease, what's the word I'm looking for? You never withdraw them abruptly, okay? The patient has to be tapered off of these medications. You never DC these type of drugs abruptly. That's for all psych meds. I'm talking about antidepressants, anti-seizure. If it's a psych med, they have to be tapered off. Drug-drug interactions, again, alcohol. You know you don't drink alcohol with drugs over the counter or prescription. All right, let's talk about succinimides. And over here, I know my handwriting is horrible, but I wrote treat absence. So the succinimides, these are the class of drugs we give to treat the absent seizures. Remember the absent seizures in part 1? I talked to you about that. We mostly see this in the pediatric patients, and very often the absent seizures, they're mistaken for that patient just, daydreaming, because the absent seizures are very short term and the patient may just look like they're staring off in space and they're blinking and they're really having a seizure, while the teacher or the parents think that they're just off daydreaming, okay? So this class of medication, the succinimides, this is what we use to treat absent seizures, okay? The succinimides are most frequently used to treat what? Absent seizures, which is a form of generalized seizure. So therapeutic actions and indications. The exact mechanism of action is not understood. So we don't understand exactly how it works, but we know it works, okay? It suppresses abnormal electrical activity indicated for the control, again, absent seizures. Your default microphone has changed to MacBook. I hope you guys can still hear me on this video. Contraindications and cautions. Obviously, if the patient has any allergy to the succinimides, you're not going to give it to them. Patients with intermittent porphyria, renal hepatic disease, pregnant or lactating, if they're breastfeeding, they're going to obviously have to find another way to feed the baby formula, because this medication does go through the breast milk. And you're going to teach the woman of childbearing age that she needs to use a barrier method of contraception. When I say barrier method, I'm talking about the condom. Okay, so that she does not get pregnant while taking this medication. Adverse effects of the succinimides: depression, drowsiness, fatigue, ataxia, insomnia, headache, blurred vision, decreased GI activity with nausea, vomiting, anorexia, weight loss, GI pain, constipation, diarrhea, all that good stuff. Here's what's important. Look at this, guys. Bone marrow suppression. Let's stop there for a second. So when you see bone marrow suppression, automatically your mind needs to be going to, whoa, bone marrow suppression. I'm not making enough WBCs. WBCs help fight infection. Patient's going to be at risk for infection. Whoa, I'm not making enough RBCs. RBCs carry hemoglobin. Hemoglobin carries oxygen. This patient is going to be at risk for being anemic. That's why they're so tired all the time. Whoa, bone marrow depression. I'm not making enough platelets, which means I'm not clotting the way that I should. I may possibly bleed out. Those are things that need to be going through your mind when you see bone marrow suppression, because remember, your blood cells are made in your bone marrow. What else can happen with the succinimide use? Potentially fatal pancytopenia. That's what I just talked to you about. Pan means covering everything. Cyto, cells. Penia, little bit of. Okay, so fatal pancytopenia, little bit of red blood cells, white blood cells, platelets, and those numbers can be so decreased it could put that patient's life at risk. Okay, dermatological reactions such as pruritus, which is the itching, urticaria. That's when the patient when they what's the word? Guys, I don't know what's wrong with, I do know what's wrong with me. I'm tired. I've had a long day, but that's when the patient erupts in hives. Hives, that's the word I'm looking for. Urticaria, alopecia, that's where their hair falls out. Stevens-Johnson syndrome, that's that fatal lethal dermatological reaction that I told you about. Google Stevens-Johnson syndrome. If you don't know what it looks like, do a Google search. Okay. Other drugs for treating absent seizures. 3 other drugs that are used in the treatment of absent seizures do not fit into a specific drug class, and these are the drugs. Out of these, if you're like me, where my brain can only hold a certain amount of information and I can only remember 1 or 2, please, for the love of God, if you remember anything, remember your valproic acid. That's your Depakine. That's the one that you'll be asked about, or that I see more often, okay, when it comes to those other drugs that do treat the absence seizures. Okay, remember that Depakine is also known as valproic acid. You need to know that drug. Therapeutic action and indications: it reduces abnormal electrical activity, it increases GABA activity. It has been used for migraine prevention, and look at this, has a pregnancy category X rating when used for that purpose. So under no circumstances can the woman of childbearing age get pregnant on this medication. So if you get a test question that the patient is being prescribed valproic acid, and what would cause you to need further teaching for this patient, and your answer is going to be something like when this patient says, they look forward to having a child, because can they get pregnant on this medication? Are they supposed to get pregnant on this medication? Absolutely not. Okay, it's harmful to the fetus. Contraindications and cautions, obviously in the allergy to the medication. The sulfonamides are also contraindicated with known allergy to antibacterial sulfonamides and thiazide diuretics. That's important to know for the valproic acid. So not only if they're allergic to valproic acid, if they have any allergies to the sulfonamides or those thiazide families, are we just going to give that medication blindly? No, we're going to hold that medication when the doctor orders and say, hey, I know you ordered this, but they're allergic to sulfonamides or the thiazide diuretics. When it is discontinued, Succinimides should be tapered over 2 weeks. We know that when it comes to these CNS drugs, we never DC them abruptly. They're always going to be tapered. Patients who take this drug should be well hydrated. Look at this, due to the risk of renal calculi development. Obviously, patient has any hepatic or renal dysfunction, we're going to give cautiously. Remember, guys, if the patient's kidney is not working the way it used to, guess what? They're holding on to these medications a lot longer. Their risk for toxicity is going to increase. If their liver is not working the way that it's supposed to, they're not breaking down those meds the way that they're supposed to, they're going to be at high risk for toxicity because the drug is staying in their body for longer. Pregnancy and lactation. Adverse effects. Valproic acid is associated with liver toxicity. So you better be looking at those liver enzymes. You better be looking at the ALT and the AST. You better be looking at the liver function tests to make sure that that liver is not in trouble. All of these drugs cause CNS effects related to CNS depression. Valproic acid can increase serum levels and potential toxicity of phenobarbital. I'm not even going to try to pronounce this drug, but you see it. Diazepam, primidone, and you see this drug. I'm not going to try to pronounce it. Let me see if I can make this. No. Breakthrough seizures have been reported when valproic acid is combined with phenytoin, that's the dilantin. So guys, if the patient's on dilantin and they get valproic acid, it's been seen that the patient ends up getting seizures. And remember, the valproic acid is given so the patient does not have seizures. So be very careful. You need to bring that to the doctor's attention if they're being prescribed valproic acid, but they're also getting dilantin. And extreme care should be taken if this combination must be used. Adverse effects, dilantin, and I put a note here, it says NCLEX, so very important for you guys to know. For clients taking dilantin, rash with itching is an adverse reaction indicating a potentially life-threatening condition that should be reported to the healthcare provider immediately. And what they're talking about here, guys, is Stevens-Johnson syndrome. I promise you're going to see this again in your academic career. You have to know this. So let's talk about nursing considerations for the patients that are getting drugs to treat generalized seizures. The information that follows primarily relates to drug therapy with the hydantoins. I talked about that in my last video. Succinimides, acetylcholine, you see this drug. Okay, this drug right here. Valproic acid and this drug right here. Okay. Anyway, so let's talk about it. History and assessment. You're going to assess them for any allergies to medications. You're going to assess them for cardiac arrhythmias, hypotension. Oh, let me scroll down. Hypotension. That's very important. Why you're going to have the patient change positions very slowly. Diabetes, coma, psychosis, renal hepatic dysfunction, pregnancy, lactation. Assess for contraindications or cautions to the use of succinimides, including, again, allergies, history of intermittent porphyria, history of renal hepatic dysfunction, pregnancy, lactation. You're going to get a description of seizures, including the onset, aura, duration, and recovery. Very, very important. Guys, when a patient has a seizure, it is your responsibility to know what kind of seizure the patient had, approximately how long that seizure lasted, what manifestations you saw during the seizure. Remember your nursing interventions that you did for the seizure. It's very, very important. That is on NCLEX. What did I write here? Look at, okay, so here's what NCLEX expects for you to know. That patient has a seizure. If they're standing up, you're going to ease them to the ground. And as you're easing them to the ground, you're looking at the clock because you need to know what time that seizure started. You ease them to the ground, you loosen up any tight clothing that's on them. If it's possible, you're going to turn them to the left side to help increase perfusion. You're going to make sure you don't put anything in their mouth. You're going to close the curtain to allow them privacy, right? If possible, there's a pillow or something you have under their head, you're going to place it under their head because when they're having seizure, you don't want them banging their head against that hard ground, right? And Right after that patient has a seizure, you're going to suction them as needed. If you were not able to turn them to the left side during the seizure, immediately after that seizure has ended, you're going to turn them to the left side. You're going to reorient the patient. You're going to allow that patient to rest. This is not the time that you're going to force them to go down to the dining room. They're going to be very tired. Allow them that opportunity to rest. You have to report to the physician everything that happened immediately before, during, and after that seizure, because they're going to base that medical plan based on what you saw. So the information that you're able to provide is very, very vital. All right, you're going to do a physical assessment, establish baseline. You're going to do a baseline ECG. You're going to check their liver and kidney function. Implementation rationale. Discontinue the drug at any sign of hypersensitivity reaction. Now, let me be specific. When it says discontinue, you're going to hold that med. Don't give it and call the doctor. Now, the physician or the nurse practitioner, who the healthcare provider, will determine how the patient's going to be tapered off the medication. So when they say discontinue, this is the context that they mean in it. Hold that med and call the healthcare provider. You're going to give the drug with food to alleviate any GI symptoms such as nausea, vomiting, diarrhea. You're going to monitor for adverse effects. And remember that bone marrow suppression is one of the adverse effects. So make sure you're looking at the CBC. You want to see what the WBCs are looking like. You want to see what those RBCs are looking like. You want to see what those platelets are looking like. And anything that falls below normal, you're going to call the physician. You're going to hold the drug if you see any skin rash, sign or symptom of skin rash, bone marrow suppression, unusual depression or personality changes. You're going to hold that med and call the healthcare provider. You're going to discontinue the drug. How? Slowly. Because withdrawing a CNS drug abruptly, that is enough to throw a patient into a seizure, okay? You're going to monitor patients for drug-drug interactions. You're going to arrange for counseling for women of childbearing age who are taking these drugs. Remember, guys, these drugs cause extensive damage to the fetus. So you have to warn them in advance. Hey, if you take this medication while you're pregnant or you get pregnant, here's what can happen. So you're going to teach them to make sure that they use a barrier contraceptive while they're on this medication so they don't get pregnancy. And NCLEX expects you to know this and provide thorough patient teaching. Again, very important. We've seen all of this again, but these are just reminders when it comes to those anti-seizure drugs. You're going to make sure you hold that medication, call the healthcare provider at the first sign of liver or renal toxicity. You're going to provide comfort measures such as skin care, giving the medication with meals because of the GI discomfort. You're going to provide patient teaching. Monitor for adverse effects, such as bone marrow suppression, such as Stevens-Johnson syndrome. You're going to be looking at that skin. You're going to monitor for drug-drug interactions. We talked about those already. Teaching. Teach patient the timing of the doses is important. To be effective, they have to take their drugs regularly as ordered. Never stop taking these drugs suddenly, because sudden cessation is enough to make the patient have a seizure. Drugs must be withdrawn slowly when it's discontinued. Common adverse effects of these anti-seizure, anti-epileptic drugs, which basically boil down to, for the most part, guys, CNS depression, okay? No driving or operating heavy machinery while on these medications because of the CNS depression. Remember, safety is going to be on the forefront of our minds. Headache and difficulty sleeping, these usually disappear as your body adjusts to these anti-seizure drugs. You have to teach that to the patient, because if you don't, they're going to say to themselves, oh my gosh, this medication is giving me a headache. This medication is giving me insomnia. I can't live like this for the rest of my life. I'm going to stop taking my medication. Boom. Before you know it, patient has a seizure. What if they have a seizure while they're driving or they're operating heavy machinery? We don't want that to happen. So you teach them in advance. You may experience these symptoms, but they will gradually resolve. And if they don't resolve within a couple of weeks, let us know. GI upset, loss of appetite, diarrhea, constipation. That's a big reason why you're going to give that medication with food. Report any of the following to your healthcare provider. This is what you're going to teach the patient. Skin rash, severe, so not just normal, but severe nausea, vomiting, impaired coordination, yellowing of the eyes or skin. That lets you know what's in trouble, guys. The liver, fever, sore throat, personality changes, and unusual bleeding or bruising. What are you suspecting when you're seeing the unusual bleeding or bruising? Bone marrow suppression. And very important, guys, this has been seen on NCLEX so many times. This patient that has epilepsy or they're prone to seizures, they need to wear a medic alert bracelet at all times. Teach them to tell their healthcare provider or anyone involved in their care that they're on anti-seizure, anti-epileptic medications. You okay? Yeah. Okay, I'm still teaching. Give me a few more minutes. Teach them not to take any other drug, including over-the-counter medications. Report and record any seizure activity that you have. You tell them to keep a diary, an activity diary, and when they have a seizure, they need to write it down in that diary and also write down what were they doing right before that seizure. Did they have an aura? Okay, teach them that and tell them to take the drug exactly as prescribed. Some key points. Drugs used to treat generalized seizures include the hydantoins, the barbiturates, and the benzodiazepines. Thank you, honey. Drugs used to treat absent seizures, and you see the list. Don't forget about the valproic acid. Do you have your cell phone with you? Yeah. Okay. Adverse effects associated with the drugs reflect CNS depression, such as the lethargy, dizziness, somnolence, etc. All right, guys, and that is it for the part 2. I hope you guys found the video to be helpful. Let me know in the comment section if there's anything that I didn't cover to your liking that you'd like to see more of. If there are any questions you'd like me to accompany with this teaching, anything you'd like to see me cover that I haven't done so already. Guys, thank you so much for watching this video. Don't forget, I have audio lessons available on my website, nexusnursinginstitute.com, and you guys will see me on my next video.